a pleasure to invite, to have this program running for the last 2 months. And we are having a discussion on various aspects of psoriasis so far. And this is the last of that psoriasis series. And we are going to have 2 talks today. One is the light-based therapy, and second is biologicals and small molecules in the treatment of psoriasis. The treatment of psoriasis is not just giving some drug or using some gadgets or not like that. It requires a very meticulous planning of the treatment. What the patient requires, what is the economic status of the patient, the logistics of this treatment availability, all those things must be taken into account for the treatment of psoriasis. However, we should know all the aspects of treatment of psoriasis. And light-based therapy, we all know that it is not very easily available in all centers in India. However, we should have a general idea of light-based therapy, especially when you appear for examination. So today, we have an eminent speaker, Dr. Binesh, to talk on the light-based therapy. And this Dr. Binesh is well known in the dermatology fraternity, and he has presented various topics in various fora. And especially, he is very much interested in the light-based therapy. And he is in fact conducting the phototherapy in Government Medical College, Thrissur. He presently is working as Associate Professor of Dermatology in Government Medical College, Thrissur. And he has a lot of experience and a lot of publications that you will come to know when he talks about his topic. Over to Binesh.
Thank you, sir. Sir, am I audible?
Yeah.
So thank you, sir, for that very good introduction. And also, I thank you for giving me this opportunity, and also the organizers for giving me this opportunity. So, shall I share my screen now?
Yes, doctor.
Okay. So I hope the slide is
Yes, doctor. Visible,
no?
Yes, doctor.
Okay. Yeah, okay. So my topic today is light-based, as sir has mentioned, light-based treatment for psoriasis. So I'll be going through these topics. As all of us know, this light-based treatment, if you take the history of that may date back to even the very ancient era in India or in other part of the world like Egypt. This has been there even may date back to around 1500 BC. Now we have got a lot of advancements in this field. So let us see what all therapies are available for treating psoriasis. So I'll be talking about UVB-based regimens like NB-UVB, broadband UVB, and targeted UVB. Then UVA-based treatments like topical and oral PUVA, and lasers like PDL, and also photodynamic treatment, Grenz Ray, climatotherapy, visible light, and also our age-old treatment like Goeckerman Therapy and Ingram. And my focus will be mainly on how to give these regimens with a mention of some evidence, if it is there, regarding these treatments regarding the treatment of psoriasis. Okay, so let me start with NB-UVB. NB-UVB, as all of us know, is a very safer type of treatment. I think many of us may be using it. So the American Academy of Dermatology. So how to start this treatment? So regarding the initial dose, the American Academy of Dermatology, they have put forth a guideline. Either we can start it according to the skin type, or just like our IADVL guideline, we can start according to them after calculating the minimum erythema dose. So this is the treatment according to for the type 4 and type 5 skin, we can see that it may start with 500 or 800 millijoules. But I think in many of our centers, we may not be starting with this much energy. And as for IADVL guideline, immediate testing is advised, and we can do it on the closely opposed photo test sites, mainly on the back of the trunk or over the volar aspect of the forearm. And it is read at 24 hours. And 70% of this MED is given as the starting dose. And this is given as alternate daily. Okay. So what's the problem with this MED testing is maybe a little bit inconvenient for the patient also. The patient may have to come after 24 hours. And also, we may also find it a little bit difficult to do that MED testing. So let us compare this NB-UVB with the PUVA therapy. And PUVA has got a lot of advantages compared to NB-UVB. PUVA has got a faster clearance, a clearance rate of 80% compared to 70% that of NB-UVB, and more likelihood of remission. But at the same time, it has got more chances of side effects or adverse effect. And regarding the cost or simplicity of the treatment, NB-UVB may be more preferable. So AAD actually recommends NB-UVB is preferable to PUVA monotherapy. Okay. Now coming to the next, once we have started the treatment, then we may have to maintain it. We may have to, so how to decide the dose on the next treatment? So what we have to do is we have to assess the erythema present in the patient. You see whether there is erythema, whether it is symptomatic or not, or are there any signs of phototoxic reaction like that. The rate of erythema is also important. The patient is coming after 48 hours. So if the patient had erythema, that is what we expect actually. We need erythema, but it should persist only for less than 24 hours. If that is the case, we can increase the dose by 20%. Then if the erythema is persisting more than 24 hours, but it is not there now, that means it is less than 48 hours, then the previous dose may be continued until that erythema is persisting for less than 24 hours. After some time, the patient may tolerate UVB, and the erythema will become less than 24 hours. Suppose the erythema is still there, it is persisting more than 48 hours, then it is better to skip the treatment on that day. And after that, we will, next dose, we will give the treatment, the dose which was not producing erythema. Okay. Just prior to the dose which produced erythema will be given on the next treatment. But IADVL has, the recommendation is a little bit different. And here, if there is no erythema, we can increase the dose by 20%. And if there is a mild erythema, if it is a barely perceptible erythema, we can repeat the previous dose and the further increments will be reduced to 10%. If there is a moderate erythema, which is a grade 2 erythema, which is well defined, one treatment. Then repeat the previous dose at the next visit, and again reduce the increments to 10% only. Instead of this 20%, we'll reduce it to 10%. If there is severe erythema, that means symptomatic erythema persisting for more than 24 hours, or presence of edema or bullae, you skip the treatment. No treatment is given until recovery, and further treatment will be given by you reduce the dose by half, and then give only 10% increments further. Okay. So this is the recommended treatment, and this was an older guideline. You can say it is in 2010. There they have advanced. So again, an AAD guideline. They have this for type 4, we can give a fixed dose a fixed dose increments, like a 45 millijoule for type 4, and type 5 we can give 60 millijoule. I think in some institutions this is being followed. And it has got the convenience that it may not produce that much phototoxic reaction very rapidly. And also this is more ideal for a home-based treatment. That will come to that later. Okay. And also there is another way in which we can give a fixed time also. And if you use a fixed time, but thing is that the joule, the energy may vary according to the type of the instrument. So again, that may be more relevant for a home-based treatment. Okay. Now, let us see, suppose a patient misses one dose or few doses in between. What is recommended is, if patient loses 1 week only, then hold the previous dose constant. Suppose the patient misses 1 to 2 weeks of treatment, then decrease the 2 to 4 weeks of treatment, decrease by 50%. More than 4 weeks means you have to return to the starting dose. And according to IADVL, this is the recommendation by IADVL working group. I think it's an older recommendation. 1 or 2 treatment is missed, we can repeat the previous dose. 3 treatment missed, treat with the penultimate dose. That is what is mentioned. And how long we will continue this? We'll continue the treatment once up to the psoriasis is clear. Once it is clear, or if there is only minimal residual activity for 4 treatments, then it can be stopped according to the IADVL. And the maintenance therapy according to AADs, there are actually 2 options. Once the psoriasis is cleared, either we can taper the dose. We can taper the dose according to the last dose. We will give the last dose given prior to the clearing, that is given twice weekly for 4 weeks, then once weekly for 4 weeks. Okay, so that is one method. Suppose we feel that the patient may need further treatment, we can't stop it, then we can continue it indefinitely. In that regimen, the final dose is reduced by 25%, and that is held a constant. It is given every 1 to 2 weeks. Okay. So that is regarding the maintenance therapy. Now there will be a question: what is the maximum dose that we can give? On the facial areas, regardless of the skin type, it is 1 joule per centimeter square. And I think for the vitiligo guideline, this has been 1,500, I think. But in psoriasis, it is mentioned as 1 joule per centimeter square. For skin type 4, it is 3,000. And for 5, we can give even up to 5,000. And I think in our setup, we usually follow this thing. We may give a maximum of up to 3,000. Now coming to home-based NB-UVB. This is actually, I think this will become a treatment in the future, because the problem for the narrowband UVB is the patient has to come every other day or at least 2 days per week. maybe up to 1 year or something like that. So, but the problem is most of the patients may not be able to come for that, for an institution-based treatment. So I think this home-based treatment is going to become a treatment choice for many of the patients in future. The advantages are that actually there have been studies which compared this. So the PASI scores or other parameters of efficacy, the quality of life indices, etc. These were almost similar when compared to the hospital-based treatment. So the burden of treatment was significantly lower and the patients were happier with this home-based treatment. So I think that will become one of the treatment options for the patients in the future. Now, what all treatments can be combined with our NB-UVB? Topical agents like, there's a mention that topical calcipotriol, vitamin D analogs are degraded by exposure to UV radiation. And testosterone has got decreased sector. Actually, or that we can combine all these vitamin D analogs, retinoids, or corticosteroids during NB-UVB. It has got a beneficial effect. Only thing is that the coal tar is not used along with it. In my, I think in Goeckerman regimen, etc., we are using either before or after that only. But used along with it may produce more phototoxicity. And also similarly, 8-methoxysorel solution. That is not recommended. Okay. Coming to the systemic treatment, we can see that all systemic treatment like methotrexate, retinoids, fumaric acid esters, biologics, apremilast, all these agents which are routinely given for systemic treatment in psoriasis can be combined with NB-UVB, and actually it has got a beneficial effect, may reduce the total cumulative dose of both. We should not combine it with the cyclo or NB-UVB is a relatively very safer option. It's very safe and well tolerated. Only thing is that we should practice some precautions, like we should give genital shielding and eye protection for the patient. And many of the studies have shown that there is not much increased risk. Only thing is that we should take some precautions in giving NB-UVB for patients with a history of melanoma or multiple non-melanoma skin cancers, arsenic intake, or exposure to ionizing radiation. Otherwise, it is a very safer treatment. And one of the contraindication, absolute contraindication, is xeroderma pigmentosum and other UVB mediated aggravated conditions like actinic keratosis, etc. And for LE, it was contraindicated, but now it is mentioned that if it is the LE patients are not having photosensitivity and if they are Rho negative, this can be given with caution with oral herpes simplex. And regarding photosensitizing medication, many of them, this photosensitization is due to UVA. So actually it is safer to deliver even if the patient is taking a photosensitive medication. This is one point I want to specify. Women of childbearing potential on phototherapy, not pregnant patients, even the women on childbearing potential. If we are giving be higher than 2 joule per day or a cumulative dose of 40 joule per centimeter square, it has been shown that there can be a chance of drop in folate levels. So it is better to supplement folate for such group. That is to decrease the risk of neural tube defect in the fetus. Now coming to the next topic, that is broadband UVB. Broadband UVB even before the invention of neuropathy. Nowadays, just become and shows not much broadband UVB. But there is a broadband UVB is more useful for patients with thick plaque psoriasis. Actually, the response to this treatment may be the thickness of the plaque may also become a factor. So in that case, the thickness for thick lesions, broadband UV may be more effective than narrowband UV. There is a theoretical proposition like that. And other parameters are just like narrowband UVB. This is a excimer laser, it's an excimer lamp, and this is our handheld NB-UVB machine. All these constitute targeted UVB. Targeted means
Doctor, I think your bandwidth is low, doctor.
Doctor?
So
that's
Doctor, your network is Dr. Binesh, doctor.
It's got a fast. Okay.
Doctor, your bandwidth is slow.
Okay.
So, yes, doctor. So that you can off your video and you can.
Oh, okay. Is it okay now?
Yes, doctor. Now it is okay.
Hello.
Doctor. Yes, doctor. Now it is okay, doctor. We can proceed.
Okay. 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 I think the slides are also visible now.
Doctor. Yes, doctor. Slides also visible.
Okay, I will continue. Okay. So the excimer laser, excimer light, and
क्या हुआ तो पहले थोड़ा सिर्फ उधर
and these are really used for psoriasis like and
Speaker, sir, kindly unmute yourself, sir. Dr. Binesh, sir, kindly unmute yourself, sir. Dr. Binesh, sir, kindly unmute yourself, sir. Doctor? Doctor
yeah, okay, okay.
Binesh.
Is it okay now? Yes, okay.
Yes, sir. Yes, now it is okay.
Okay. I'm sorry. So I will start with the previous slide now. Is it okay now?
Yes, doctor. Now it is okay, doctor.
Okay. So for we take the efficacy, that's the endpoint is HIV PASI 75. Excimer laser is the most effective one compared to excimer light and followed by targeted NB-UVB. And topical PUVA has got a comparable result to excimer light. And it is targeted NB-UVB. So we got the adverse of effect compliance. And there is no evidence for this high dose of dose, like 6 to patient. Now, what is this targeted treatment? Targeted phototherapy. Again, there's fixed dose protocol or according type or according to the NB side. And also should take into consideration characteristics like this location of individual lesion. Thickness is mild. You can, for skin type 4 and 6, we can start with 400. For a moderate one, it is 600. Severe one, we can start with 900. And for the subsequent treatment, again, we have to, just like in the case of NB-UVB, we have to look for the erythema and also the response. So if there is no erythema, we can increase the dose by 25%. If there is light erythema and there is no significant improvement, if there is erythema, then we have to, again, that increment is reduced here to 15%. If there is mild to moderate erythema at 12 to 24 hours, we maintain the dose. And once that considerable improvement occurs with plaque thinning or reduced scaliness or pigmentation, we can either maintain the last dose or it can be reduced by 15%. Suppose severe erythema occurs, then it is we have to reduce the dose. Remember here, when the erythema occurs around the blister, not treat the blister until it becomes. Now coming to the UVA-based treatments, we start with topical PUVA. Either we can combine it with the solution used is a 0.1% air-methoxysoralen solution. And in for topical PUVA, and what is available is a 1% air-methoxysoralen solution. So either it can be mixed, or it can be mixed with an emo. If you do a topical 20 minutes before UVA. For other types, like if you want to give a PUVA soak or PUVA bath or bathing suit PUVA, whatever it is, the proportion is, this is actually 0.75 ml of 1% air-methoxysoralen in 2 liters of water. That is the recommended one. This is an AAD recommendation, but I think in IAD it is a little bit different. It is actually 0.75 ml of 1% in 2 liters of water. So that the final concentration will be 3.75 milligram per 1 liter. That is the concentration we have to okay. So we can remember this proportion. 0.75 ml of 1% air-methoxysoralen in 2 liters of water. Okay. And if it is a soak, it is soaked into the hand for 30 minutes before UVA. And remember, it has got an therapeutic window, may lead to phototoxicity. And another way is we can give sunlight also. Here the exposure time initially is 4 to 5 minutes. And every week we can give a 1 minute interval. The maximum is 30 minutes. This we can remember because this is the maximum time usually that we follow in whether it is oral PUVA or PUVA sol. We have 30 minutes. This is that either we have to take 1 ml of 0.75% of is not available. What is available is 1% solution. So we can take 0.75 ml of 1% solution in 2 liters of water. So the final concentration will be about 3.75 milligram per liter. This is the concentration that is needed. Okay. So the initial dose of UVA is 5 0.5 to 1 joule per, initial dose is 5 joule per centimeter square. I think in most of the institutions, we start with only a very lower dose. We start with the 0.5 or 1 millijoule. Then we give an increment of 0.5 to 0.5 joule only. What is recommended is we can give increments of 0.5 to 1 joule per centimeter square. And the frequency is thrice weekly, alternate daily for 3 days. And remember, dorsa of the hands need only 50% of the dose for pumps and salts. And bath PUVA is a little bit difficult to administer. Here, again, mix the psoralen in a bath water. So again, the proportion here also. Here, if it is 100 ml of liter of water is 37.5% psoralen. This is not available. That is why I'm telling it will be 37.5 ml of 1% solution in 100 liters of water. And this is less effective than oral PUVA, but it may be associated with side effects. So it is better to apply all the restrictions of oral PUVA to this bath PUVA also. The disadvantage is also it has got a lot of disadvantages, like it requires more infrastructure, like nursing staff, space, the regular cleaning of the bathtub, and immediate availability of the PUVA therapy after bath, etc. So maybe a little bit difficult to administer this. And Devil has recommended a lot of guidelines for bath PUVA. And remember, sunscreen should be applied and protective clothing worn after treatment. Cancer clearing will occur. We need a separate room, bathtub, geyser, then the psoralen solution. Here we can see that correct quantity, 37.5 ml of 1% 8-methoxypsoralen in 100 liter of water. So 10 minutes supine and 10 minutes in prone position. The whole body is immersed. Okay. And we have to clean the bathtub with liquid soap. And bathing suit PUVA is another method where we use a bathing suit made of flannel. It is a water absorbing material. And we need a plastic bucket and raincoat. Prepare the solution as mentioned previously. And dip this bathing suit for 5 minutes in that solution. Take it out, gently squeeze it, and ask the patient to wear it for 15 minutes. Then put a raincoat, and immediately after 15 minutes, we will be exposed to UVA. Okay. So that is bathing suit PUVA. Now coming to oral PUVA. Oral PUVA, we give by administering 8-methoxypsoralen followed by UVA. So it has been mentioned that if we give maintenance treatment with oral PUVA, it may maintain the skin clearance at a higher rate. And also it can be combined with the retinol safety. It is more effective than either treatment alone. And this is the mechanism by which PUVA works. It produces DNA crosslinks with DNA crosslinks and may produce anti-proliferative, angiogenic, anti-angiogenic, apoptotic, and immunosuppressive effect. So this is the dosing of 8-methoxypsoralen. If the person is less than 30 kg, we can give 10 milligram. This is the usual way I think we may come across. We can give 20 milligram. The patient is more than 66 kg, you can start with 30 milligram. And what is the maximum dose of UVA that can be given? Here it is mentioned as for type 4 it is 12 and type 5 it is 20. I think in many of the institutions we may stop by 10, but we can go up to 12, and type 5 we can go up to 20. And the initial dose here it is 2, and we can give increments of 1 or 1.5 according to the skin type. And IADVL has mentioned the initial doses 2 to 4 for type 4 skin, and type 5 skin is 2.5 to 5 joule, and increment is 1. And remember, genital lesion should be only 25% of the regular dose. So IADVL has put forth a lot of guidelines for giving PUVA therapy. And we should first determine minimum phototoxic dose. This is read after 72 hours. Actually, that reaction occurs maximum after 36 hours. So this reading is taken at 72 hours. And we start with the 70% of the minimum erythema dose and an increment soon. 20% per session or per week is given. Okay. Or we can follow a fixed dose regimen also. So once the clearance is attained with the 90% lesions, we can terminate this phase. So initially, treatment we may require 2 to 3 times a week. So once a mild erythema is present, it is reduced or kept constant, and moderate to severe erythema, treatment is deferred. And may require an average of 20 treatment, at least 15 to 25 treatments for clearing. Okay. The dose may be around 5 to 20 joule. And we may have to maintain the treatment with them. And for that, the last dose of clearance phase is kept constant. Frequency is reduced slowly as low as 1 per month. Sometimes we may come across relapses. So after treatment, this can occur after discontinuation of the treatment or even during that maintenance treatment we may come across. In that case, we may have to increase the frequency. Now coming to PUVA salt. Here we are, instead of UVA, we are using sunlight. The problem is it may depend upon the season, time of the day, latitude, and condition of the atmosphere, etc. And also there is a difficulty in quantifying the UV light. So it has got all the problems like this: lack of privacy, difficulty in monitoring the dose, etc. So the final problem may lead to undesirable effects. So ideally, 8-methoxysoralen is taken after breakfast, even that is 12 in the early morning. I should advise the patient take it after breakfast, otherwise it may produce nausea. And the UVA is administered 1.5 hours later. And what is the best time for that? In some endpoint, 9:15 to 11:15 and 2:30 to 3:30. In IADVL, it is mentioned as 10 to 11 a.m. or 3 to 4 p.m. Then exposure is increased. So this is PUVA salt. So we can increase exposure 5 minutes every week, and maximum is 30 to 45 minutes. IADVL maximum. So we can remember it is a 30 minutes for this PUVA salt. That is topical PUVA salt or systemic PUVA salt. So 30 is the maximum dose. Okay. And remember, the patient should be advised to use eye protective glasses and avoidance of further sun exposure for next 8 hours. Okay. This is important. So these are the precautions to be taken: the sunscreens, the goggles. Also, treatment should be protected with a cloth or an athletic supporter, ideal dose. Some avoidance should be advised. Okay, and UVA emitted by common fluorescent light are insufficient to activate soil, so that will not produce much problems. So these are the risks. And considering the long-term risk, this is in our type of skin, this may not be that much applicable, but it has been mentioned that the patient is taking more than 350 treatments. There is an increased chance of SCC, especially in the whites and other fair-skinned individuals. Okay. So these are the contraindications. It is contraindicated in persons younger than 10 years. It is 10 years. Also, pregnant patients or xeroderma pigmentosa, this is contraindicated. And also use it with caution in this age group, 10 to 18 years. And those who have history of dysplastic nevi, non-melanoma skin cancer or photosensitivity. And also exposure to carcinogenic agents like ionizing radiation or arsenic, or even the photosynthesizing medications. Here we should take precaution. Okay. Now coming to the other modalities of treatment, photodynamic therapy. This is administered using photosensitizers like 5-aminolevulinic acid or methyl aminolevulinic acid. The light source used include either LED, helium, neon, IPL, or other visible lights. They produce the light, so that may lead to PDT-induced apoptosis of T lymphocyte. The major absorption peaks include blue and for ALA and red for methyl aminolevulinic acid. But still, there is no thing. It's only minimally effective. There is no strong recommendation for it. And Grenz has been my choice. Resistant localized, sorry, a dose like this, 200 weekly intervals, up to a total of 800 to 1000 rad. Maximum is 5000, and you should give a 6-month rest in between. There is only limited literature regarding Grenz Ray. Next, another. Say the Dead Sea, Black Sea Coast, Blue Lagoon, or Canary Islands. Some races favor this climate features, etc., in treating patients with psoriasis. Either they can go there temporarily or even, yes, or even permanent, is it? So, what is available here? Here, consultation with the medical professionals, psoriasis education, group discussions, daily physical training, individualized exposures, psychosocial support, and other novel components available in this UVA, only very low percentage of UVB. So it will not produce much erythema. And also the and mineral infused moisture with diffuse so rich that they will anti-proliferate for the relevant also climatotherapy has also got a very important role in treating psoriasis. So there is anyway there is an apparent transient nature. The beneficial effects are only transient, but this is, remember, this is one method treating psoriasis. Blue or
Doctors, kindly bear with the doctor's speaker bandwidth is less, so he will join shortly. Just a moment.
Hello.
hello, am I audible now?
Yeah.
Sir, Binesh sir, your bandwidth is very low. Okay. I think so, sir. In between, we lost your voice also, and also your sharing also. Oh.
Okay, now is it okay?
Yes, sir.
Now it is visible, no?
No, sir, it is not visible. Your sharing is not visible. Sir, your
not visible.
It is not sharing, sir. It is not visible. Sir, or else we will
okay,
do
I
one thing, sir. Yeah. Brendan, sir?
I'll do it once.
Okay.
Pardon?
Sir, Crichton, sir. Sir, in between, shall we do our Abdul session, sir?
Shall I do it once more?
Binesh, you can
Yes, sir.
after the Dr. Abdul Samad's talk, you can project the questions.
Okay.
Okay. Thank you,
So
Dr.
the presentation is not over, sir.
It's not over. Okay. Then you can continue.
Not over, sir.
You continue.
Okay, sir. So I think some technical problem occurred in between, I think.
Right. You can share the slide.
Is it visible now?
Yeah, it is visible.
Okay, sir. So I'll finish it within 5 minutes, sir.
Okay.
Now coming to the next treatment modalities, pulsed dye laser. So this is used for main use is in nail psoriasis. It has got advantage on onycholysis and subungual hyperkeratosis. And nail pitting is the least responsive one. So it can be recommended as a treatment option for nail psoriasis. And regarding next one is a low level light treatment. Here we use either a near ultraviolet or LED, helium neon, or gallium arsenide laser. So the advantages are this is non-invasive, it has got only few side effects and it has measurable benefits, but the use of this has to be explored in the treatment of psoriasis. And for nail psoriasis, the one which is recommended is PDL. And also we can use the photodynamic treatment, laser or IPL. This Goeckerman therapy. Goeckerman therapy was there from 1923 onward. So here we use 1 to 5% truth culture in combination with UVB. This is given 5 days per week. It has got the advantages of inhibiting angiogenesis and keratinocyte proliferation, decrease T lymphocyte numbers in the skin, and also alter the inflammatory cytokine expression. So we had got a rapid and robust clinical response, long duration of remission, and low adverse effect profile. Okay, so this is actually an attractive option for treating psoriasis, though I don't think we are using it very regularly nowadays. This is an Ingram regimen. This utilizes initially a cold tar bath is given, then your patient is exposed to UV light, and after insulation is secured by a paste in ethanol in, and this is allowed to dry. The patient can go dress and pursue normal daily routine and return to treatment for next day. Okay. As far as we can, so to conclude, so phototherapy is one of the main modalities of treatment in psoriasis. Though I have mentioned a lot of guidelines, we can find that we cannot follow all the guidelines very strictly. So according to our patient, according to our machines, we may have to make slight modifications. Remember, NB-UVB is like home NB-UVB or like low level light therapy, etc. And still, we are not utilizing our age-old treatment. I think it is all underutilized. The Goeckerman regimen and Ingram regimen are not utilized nowadays, I think. So I think they can also be incorporated into the treatment armamentarium. So these are my references. So thank you for the patient listening.
Hello.
Yes, doctor.
Thank you, Dr. Binesh, for an elaborate presentation. Now there is a problem. Dr. Samath is having some urgent call, so may not be possible for him to continue the talk. So I think we will postpone his talk to some other date in a convenient time, convenient day. So I think Dr. Binesh, you can start asking questions and then we will wind up the session.
Doctors, and when the questions comes, kindly put it in the chat box, your answers. Yes, doctor, you can start asking questions.
Sir. Yes, sir. What should I do?
You put the questions.
Should I stop my MCQ now?
Yeah.
Okay, sir. One by one. Okay.
Yeah.
Okay.
Doctor, per question, you will give time 1 minute.
Okay.
The first correct answer will be.
So I will complete the 5. I have got 5 questions. I will complete it in one session. No. Okay.
Yes, doctor. Doctor, after flashing first question, just to wait to give a time, doctor. 1 minute. I will tell doctor. Then you can flash second question.
Next. Okay.
Yes, doctor.
Sure.
Like that.
Okay. So, this is the first question. Is it visible now?
Yes, doctor. Visible, doctor.
Okay. So tell me when to go to the next. Okay.
Yes, doctor. Doctor, your time starts now. Please put your answers in the chat box. Yes, doctor. You can shoot second question, doctor.
Okay.
Doctor, second question, time starts now.
Shall I go to next?
Yes, doctor. You can go as next, doctor. Doctor, start responding to that question.
So next question. Is it okay? May I go to the next question?
Avid?
1 second, 1 second, 1 second.
Shall I show the previous one?
No, doctor.
Okay.
Doctor, again, fourth question came.
Okay.
Yes, doctor.
Yes,
Wait.
yeah.
Yes, doctor.
Okay.
Yes.
May I go to next?
Yes, doctor. Can go next.
This is not an MCQ.
Yes, doctor.
You can just write the sequence. Okay, just write the number.
Yes, doctor.
So, okay.
1 second, doctor. 1 second.
Okay.
Yes, doctor. Doctor, the response has sent to you via WhatsApp, doctor. You select the winners and reveal the results, doctor. I sent
have
you
to
via
select the
WhatsApp.
winners.
Yes,
Oh my
doctor. I
God.
sent via yes, doctor. I sent in the WhatsApp the responses. The first correct answer takes is the winner, doctor.
Oh, it may be a little bit difficult for me to.
What is the correct answer, doctor? First question, I'll tell.
Okay. Okay. Just tell me. That will be more easy. I will tell you that.
Yes,
Okay.
yes, doctor.
I will tell you the answer.
Yes, doctor.
First question is B.
B.
B for bag.
Okay, so the winner is Dr. Chinmay Yadav. First question is
Okay. Okay.
Dr. Chinmay Yadav.
And second question is answer is C.
See, then I don't know the name, but it is given iPhone. So we'll let us ask. We will after getting this, we will ask doctor. Third one, doctor.
Okay. Third one is B again. B1 for
B.
bag.
So that is Doctor. Let us take Dr. CMA. Dr. CMA. Okay, doctor. CMA is iPhone.
So four is D. D for dog.
Okay, doctor. 4 is D means Dr. High Cool. High Cool is Dr. Aralmoli Rajan. Yes, doctor. Next one, doctor.
Okay, next is the order is 2413.
2413. So Dr. JS.
Okay.
Okay. Dr. Chinmay Yadav. The first question winner is Dr. Chinmay Yadav. Doctor is there?
Yes, sir.
Madam, you are from madam?
Jodhpur, sir.
Pardon, ma'am?
SN Medical College.
SM Medical College.
Yes,
State, madam?
Rajasthan.
Rajasthan. Okay, madam. Rajasthan SM Medical College. Okay, madam. Okay, madam. Year of studying, ma'am.
Sir, I'm a third year, sir.
Fine,
This my
fine,
exam, sir. Yes, sir.
fine, madam. And the second question winner is Doctor. It is not mentioned iPhone. It is simply iPhone is there. May I know whose name it is? iPhone. iPhone. And the third is CMS iPhone. Ma'am, you are there, ma'am. CMS iPhone.
Seema.
Madam, you're from, ma'am?
I'm from MVJ Medical College, Bangalore.
Bangalore? Which college?
MVJ
Madam?
College.
Yeah, MVJ.
Yeah,
Okay, madam. Madam, which year of studying, ma'am?
final year.
Fine. Okay, madam. Then high school it is Dr. Aranmoli Rajan. Am I right, sir? Dr. Aranmoli Rajan? Aranmoli Rajan is, I'll take care. Dr. JS? Sir, are you there, sir?
Hello, I'm
Yes,
Dr.
doctor.
JS. Jaswant
Madam.
Shvedkar.
Madam, your full
Jaswant
name, ma'am?
Shvedkar.
Madam, your full name, ma'am?
Jaswant Shvedkar. Hello, can you hear me?
Yeah, madam, I think there is disturbance. Can you please put, yes, I got it, madam. Jaswanti Shitokar, I got it, madam.
Queen's
Madam,
Hospital, Bangalore.
okay, madam. Jaswanti.
Second.
Okay, madam. Yes. And the second question is Dr. Payal Agarwal is the correct answer. Madam, you are from, madam? Dr. Payal?
Sir,
Pardon, ma'am?
Gandhi Medical College, sir, Hyderabad.
Okay, madam.
Gandhi Medical College, sir.
Okay, madam. Okay, madam. Gandhi Medical College. Fine, madam. Fine. Thank you. Thank you, doctors. Dr. Crichton, sir.
Yeah, thank you, all the participants. Of course, we could not complete the today's webinar. The biologicals and small molecules we will have the talk at a later date, which we will schedule and do it. Don't worry. Next month we will announce the date and the topic much earlier, and hope it will go smoothly. So we are sorry for some disturbance that had occurred in between. So it is not purposeful. It is all part of the game. So bear with us. Next time, I think we will have a better transmission. So thank you all. Thank you, Dr. Binesh, for your very lengthy presentation. Okay.
Yes, doctor. These 5 winners are requested to put their mobile number in the chat box so that it is easily for it to get certificate without any printing mistake. Dr. Chinmay Yadav, Dr. Payal Agarwal, Dr. Jashwanti Shikoder, and Dr. Aranmoli Rajan. Kindly send your mobile number. Please put it in your mobile number. Yes. Okay. CMA iPhone, the doctor. Yes, sir, I got it, sir. Thank you so much for East West Pharma giving wonderful opportunity. And doctors, kindly share this notification to your colleagues also. So let them also be benefited. And really, we are heartful thanks for Dr. Crichton, sir, for arranging wonderful program regularly. And the event will continue for the benefit of our postgraduates. Thank you so much, doctor. Doctor, shall we close, doctor?